we knew those patients inside out for sure. We spent so much time with them. They were also part of the team to make this development, because you also need the patient to be able to trust us to go into this pioneering surgery and spend so much time with us. It was like a miracle, lève-toi et marche. So yes, I was so shocked and so amazed that I ran to get Pierre Pollak, who couldn't believe it was just the stimulation. He thought I'd given the patient medications to. So it was quite an extraordinary moment, yes.
Welcome to Stimulating Brains.
Hello and welcome back everybody to Stimulating Brains episode number 7. I'm really excited to talk with Professor Patricia Limousin today. Patricia is a consultant at the National Hospital for Neurology and Neurosurgery in London. She was the person to switch on the first bilateral STN-DBS patient that we already heard about with Pierre Pollak in Grenoble. So she was really there when it all started. Patricia is one of the true giants of our field and has had tremendous impact on the history of DBS and continues to shape our field today. So I'm looking forward to an exciting episode with Patricia today. So Patricia, thank you so much for taking part in this. And to break the ice, first question would be, what do you do if you don't care for the patients and aren't involved in science? So what do you do in your free time?
What do I do in my free time?
Do you have free time at all?
Well, I try to have some. Okay. I try to have some free times. I like outdoor activities. I like going to the park for walks, or I do horse riding as well.
Oh wow!
When I have more time, like holidays, I like traveling. I've got 2 daughters, so for a long time that they occupied a lot of my time, and they are now at university, so I still enjoy spending time with them, but less time pressure.
Makes sense. Do you have a horse, like for real?
No, I don't have my own horse, but I go to a small stable where I pretty much have always the same one, so it nearly feels like I have one.
Sounds good. Great. So let's dive into deep brain stimulation and neurology. So maybe weird question, what's your favorite brain stimulation target?
Well, it's got to be the subthalamic nucleus, really.
Sure.
Not only because a lot of my work has been focused on that target, it's also because it's the most interesting, in the sense that it's the one that brings improvement in a broader range of symptoms, but it's also the one that's more challenging because there's more possible side effects, and there's quite a lot of complexity with all the different connections, and there's still a lot to understand there.
So Marwan Hari said in the STNs things happen. So why do you guys hate the GPI so much?
Well, it's not that I don't hate GPI.
I know,
it does its use, but it's a bit more boring as a target, because
makes sense.
You turn it on and not much happens, and then maybe a little bit builds up. It hasn't got the same acute effect. So as I say, it has its use, but it's a less challenging, less exciting target.
What I personally really like about the STN is that it seems to receive input from more or less the whole frontal cortex, and that makes it so interesting also from a neuroscience perspective, that it is somehow maybe a miniature of the cortex, because everything projects to the STN somehow, or a lot of regions at least do. So I agree with you. It's really exciting. So maybe speaking a bit more about your career and the work in research, who were maybe defining role models and why? Did someone truly stick out? Who influenced and shaped the way you think about neurology and the brain?
Well, it's definitely Pierre Pollak. I went into neurology with him even as a medical student and then as a registrar, and we worked very closely many years. And he's the one who taught me both the how to conduct rigorous assessments of patients, how to try and keep up with research, and how to try and integrate all those things, keeping always the patient at the center of the care, but trying to make science progress. So I mean, there has been many people, but he's certainly the main one, I would say.
Would you have a story of, I mean, I'm sure you have a lot of stories of academic success, but maybe one that you want to share?
I mean, I suppose it was still a surprise when we observed the impact of STN stimulation in patients, because we were used to the effect of thalamic stimulation, which is quite striking on the tremor, but it's only the tremor. But when we realized in the early patient with STN stimulation that in some patients it could nearly have as much effect as levodopa, that was certainly a very striking moment that went above our expectations.
So Pierre Pollak, as you maybe know, was on the podcast before, and he told us that story when you turned on the first bilateral STN-DBS patient, and he later said that maybe his whole career could be summarized by this event somehow, or it really is a summary or a great anecdote to describe what he did in his academic life. And I think it would be amazing to hear it one more time from you, because you were there as well, obviously. So what led to this event when, the first bilateral STN-DBS patient was turned on, and then what happened?
Yeah, it like I just mentioned before, it's because of the major impact it had. So, when patient had a unilateral stimulation, you could see some unilateral effect, but there was no major effect on their axial function. But this patient who was very akinetic rigid and without medication, very, very limited ability to walk, could suddenly, stand up and walk. So he was such a, and immediately, that's another nice thing about STN stimulation. You can see most of the effect immediately. So it was like a miracle, lève-toi et marche. So yes, I was so shocked and so amazed that I ran to get Pierre Pollak, who couldn't believe it was just the stimulation. He thought I'd given the patient medications to. So it was quite an extraordinary moment. Yes.
And it was completely off medication, and then you turned and the patient could walk. Okay.
Yes, that was just one of those marked effects.
Do you think the most contribution to this general success back in the Grenoble time, and we'll come to that again, of course, anyways, but do you think the most contribution was on the surgical side or on the neurologist side? So Benabit or Pollak or both, or what looking back, what do you think? Who was
it's really a teamwork. It's really a teamwork that also had inspiration within the basic scientist work. All the work done in the subthalamic nucleus with Bergman and Tipu Aziz, etc. But then, it was a combination of the surgeon daring to put electrodes there and the neurologist seeing the opportunity and then doing all the work of programming. And so it's really a team. It's really a teamwork.
Right. I once talked to Paul Crack about this, about these years as well, and he once said that you could still somehow write books about these very first patients because the relationship with them was so intense, and also Pierre Pollak said that he spent days with them testing different parameters and so on. And then in preparation, I asked just now Julian Neumann whether he also has another question for you that I might ask. And he asked, do you still remember your first DBS patient? But I think probably the answer is yes, right? That you still remember these.
Yes. No, I mean, in particular, the first, at least 5 or 6, really, yes, it was very an intense intense work, and yes, we knew those patients. We knew those patients inside out for sure. We spent so much time with them. They were also part of the team to make this development, because you also need the patient to be able to trust us to go into this pioneering surgery and spend so much time with us to try and make it work better. So they are also part of.
They were part of the team. I love that. That's great. How did you get into neurology in the first place, and then maybe how did you get into DBS?
Yes. Well, I wasn't expecting at all to go into neurology when I went into medicine. I'm from quite a rural part of France, and nobody in my family had ever been a doctor. I mean, nobody had even gone to university. And because in that rural area, there were not that many jobs if you're quite academic or, if you're quite good at school. So I decided that I would do medicine to be the GP of my little village.
Makes sense. Mm-hmm.
But during the medical study, you do rotation in the different departments, and when I did a rotation in neurology, I fell in love with neurology. I did find that so fascinating. In particular the clinical examination and the link with the physiology and the anatomy, and it was the early days of deep brain stimulation in the thalamus, so I very early got involved into that, and that's that's what happened, really.
The rest is history. Okay, and we have talked about, or I asked you the question about academic success or surprise, and maybe as a counter question, is there also a story where things went wrong, or they just didn't work out as planned, or a story where afterwards you said, this was a complete waste of my time?
I don't know. I mean, obviously there has been things that didn't necessarily lead to a very interesting discovery or to papers, but I think you learn from all what you do, and I don't think there's anything I would say that was a waste of my time, and I shouldn't have done that, to be honest.
Great, super. Okay, so maybe diving a bit deeper into these early days in preparation for this, I read your paper in The Lancet 1995, and there you reported about the 3 first bilateral STN-DBS patients. And of course, needless to say, that was a big success, and we all know that, a lot followed. But reading it from a modern perspective now, one patient was confused for 2 weeks after surgery. Another developed neuropsychological impairment due to thalamic infarction, which then improved over 3 months. and one stimulation could induce ballism. So how did caring for these very initial patients feel like?
Yes, well, those patients did spend a lot of time in hospital, and did spend a lot of time with us to try and adjust the parameters and all those things. And surgery at the time were very, very long.
Sure.
Surgery would last easily more than 12 hours with a patient awake. And there were, these several trajectories on each side. So, of course, a number of patients were confused afterwards. Fortunately, many of them, most of them did recover. But there were certainly... there was certainly a number of problems on the way. It wasn't always all straightforward. But we had a good team working closely together and helping each other. And we had also patients who were very motivated and who could see the broader picture in some ways.
Yeah. One of the three patients developed stimulation-induced ballism, and you have to correct me if I'm wrong, but based on my own limited clinical experience, this doesn't seem to happen that often anymore. At least, not very, very frequently.
Yes.
But we know that, of course, surgeons shied away from targeting the STN exactly because of that, right? With lesioning already back way before that, out of fear of hemiballism. And as far as I understood, only with the Bergman paper in 1990 in Science that showed promising effects in non-human primates with MPTP-induced Parkinsonism. Only then we began carefully targeting the STN. And to me, there's somehow a little bit of disconnect, and I wanted to pick your brain. Why does DBS not frequent or more frequently induce ballism? And maybe why did it do so in this one patient back in 1995? Was there something different back then? Different electrodes? Okay.
Well, I think a lot of the difference is the way you program the stimulation.
Okay.
We have learned that you can induce ballism, and actually you can quite easily induce this ballism. At the time, we didn't know that you had to reduce medication. We didn't know that you had to increase the stimulation rapidly. So that particular patient, actually, which is also quite a slightly funny anecdote. So the other two patients didn't have very much levodopa-induced dyskinesia, so I think those were less sensitive to the ballism effect. But for that particular patient, I had increased the amplitude. The day I turned on the stimulation, I had increased the amplitude to something like 3 volts, and I left the patient in a room to go and get something. And when I came back, the patient was on the floor with ballism, feel like he was having a seizure. And at the same time, he was laughing terribly. So we learned from that there is a possibility of ballism, in particular if you increase the amplitude quickly and if you don't reduce medication. Some patients are more sensitive than others, but I think if you really go too high amplitude, it's not so uncommon. Okay. But the interesting thing is later on we realize as well that this patient who's been published at some of the more psychological effect of the stimulation, he was actually laughing because of the stimulation. He wasn't just laughing because he was on the floor, mm-hmm. wiggling around. So, there was so much to discover at the time.
Of course, yeah. But that just to follow up, would that mean if we rapidly stimulate, so increase the voltage, then we can still, often induce ballism? And is frequency, does that also play a role, do you think? Because back then the 130 hertz weren't established, right? So
yes.
Do you remember?
I don't know. I don't think anybody has really studied the effect of the frequency in in that, in inducing dyskinesia or ballism. So there's probably a role of the frequency, because I think with different frequency we influence pathway differently. But I don't think it's been studied in very much depth yet.
Makes sense. Okay, fast forward to the year 2020, the terrible COVID year. Imagine you get to know an STN-DBS patient out of your professional context, maybe privately as the husband of, a remote friend or something. Do you sometimes stand in awe of, how much you, together with the team in Grenoble, have changed the world for the better, seeing DBS for Parkinson's that had a tremendous impact on, I think, around 200,000 patients, and that's the official numbers. I think it's much more in reality. And you played a major part in making that happen. How does it feel like?
I don't know. I don't really think about it like that. I feel like I was just a little brick in a big building where lots of people have contributed. And things don't just appear; they get transformed. There are different things that get together to gradually evolve. But it's certainly been a therapy that has benefited many patients. And even in 2020, we don't have any surgical therapy superior to that. Even gene therapy or cell therapy, nothing has been as reliable and as effective.
In fact, I also was briefly in contact with Christian Moll just today and asked him, do you have another question for Patricia Limousin? And what he said was, do you think the results got even better at all over the last 30 years? So going in line with what you just said, we have nothing that compares to STN-DBS. Do you think it got better at all?
I don't know, honestly. I don't know. I think probably there's a bit less morbidity. Surgery is shorter. They tend to be less struck, so patient might be a bit less commonly confused, etc. There's still a variability in outcome. There are still patients who do amazing and patients who do less well. There has been some progress, like, we do have directional electrode, we do have bigger range of parameters. I'm not sure it's made a huge difference, to be honest.
Do you think closed loop DBS will make a big difference? Could that, or could?
I don't know. I don't think the technology we have at the moment is necessarily going to make a huge difference. I mean, if it works, it's already something. I mean, if it works as well, it's already something. But I think for it to really go to the next level, we might need much more complex system in terms of analysis of the signal and the response of the stimulation. I think the current closed loop are still quite basic if you compare to the function of the circuitry.
Makes sense. There was I don't know if you attended, but there was this DBS conference today, and it's also tomorrow, organized by the team in Düsseldorf, I think, and they had these battle talks, and one was closed loop, are we ready yet? With Mike Oken saying yes, we are, and Sergio Groppa was the contrahand defending that not yet option. So you would also think, and I think the question was ready for clinical routine. So hearing from what you just said, you probably also would think, it might work, but it's probably not going to supersede continuous DBS, but there might be promising results in the future. Or what's your position on that?
Yes, I think it's an interesting area of research. We still have to demonstrate that it's at least as good with longer follow-ups.
Yeah.
But then to be better, really, I think it's still too simple at the moment.
Yeah. Okay. There was a second, maybe since we're at it, there was a second battle between asleep versus awake DBS, and asleep was, I think, the talk was held by Patrick Blomstedt, and awake was by Christian Moll. What's your opinion in that?
Well, we do asleep in London.
I know,
I've done awake for many years, both in Grenoble and for a number of years in London. We were doing awake as well. I mean, I think asleep is obviously a lot more comfortable for the patients.
Yeah.
And for the majority of patients, the outcome is not that different at this point in time. So I think if a surgeon is used to doing it this way and has other good means of localization, it is a very valuable method.
Yeah.
But I think different surgeons have different experience, use different methods. So I think it's important to be able to analyze the outcome and see and be able to assess its own methods. I don't think everybody's got to do the same thing.
That's a good take. Yeah. And maybe the last battle talk they had was for OCD DBS. The question was STN versus ALIC, and you're probably biased because of the STN already, but even more so because Paul Kruk gave the STN lecture and Damien Dennis the ALIC lecture. So any thoughts about STN-DBS for OCD?
In our center, we did a small trial where we implanted two systems. We implanted the subthalamic nucleus and the anterior limb of the internal capsule, and patients were randomized one target, the other target, or both targets.
The Tyagi et al.
It was only 6 patients. It was a small trial. And it was quite heterogeneous. Some patients had really very good effect with the anterior limb of the internal capsule, and some patients had good effect with the subthalamic nucleus.
Okay.
I'm not sure I would be ready to say which target is better. I mean, the anterior limb of the internal capsule needed a lot of electricity, which is a downside. But some patients had quite remarkable effect. And I would say after the first patient with bilateral STN stimulation I mentioned earlier, the second amazement of my career is one OCD patients. Because as the neurologist, we were programming the stimulator, and the psychiatrists were doing the assessment. And there was this young lady who had been living in institution for years because her OCD was so severe. And she would normally take several hours in the morning to get ready. And I had turned her stimulator on one afternoon, and I went to see her the following morning, and she was already dressed and ready. Overnight, she had improved tremendously. So that was also quite impressive.
Amazing. Was that in the STN as well?
No, that was in the anterior limb.
In the ALIC, okay. Would have been funny to have the same.
And for her, actually, the STN didn't do that much, but we had other patients who did well with the STN. So I don't know. My experience is too limited to choose between the two, but it can certainly have also a very dramatic effect.
But in general, so that sounds like you're convinced OCD DBS makes sense.
Yes.
Yeah. And why do you think that at least sometimes the same target, such as the STN, works for both diseases, and it seems to also work for dystonia. And there are even people using it for Tourette's disease. Why do you think that is? How can we use the same target to treat so many diseases?
Well, as you know, all those diseases involve the basal ganglia circuitry, and sure. the STN is quite one of the centerpiece of the basal ganglia circuitry. So that probably explains it. Although, of course, we still need a lot more of understanding of which circuit we really influence.
Yeah. So you moved from Grenoble to London in 1997, and then I think you defended your PhD with the topic STN-DBS for Parkinson's disease 1998 in Lyon still. Why London? Why England even?
Yes. Well, I actually first came to London in '95 for a year to do a fellowship where I worked with John Roswell in the what was Human Movement and Balance Unit, and also David Marsden was around there. So I spent a year in London and came back to Grenoble for a while, and then I finally came back, mostly for personal reason at the time.
Was DBS already established back then in London, and who was the team?
Yes, not very much in London. Thibaut Azès was one of, and Steve Gill were the two main surgeons at the time. One in Bristol, one was in Charing Cross, and then moved to Oxford. At the National Hospital for Neurology, there was little deep brain stimulation activity. There was surgeon David Thomas who did a few, but his interest was more in another area of neurosurgery, and then he was close to retirement age. So we did have quite a difficult phase of a few years, not having very much surgery, and then we managed to recruit Marwan Harris, and we were very fortunate to develop our team, which has been a great team to work with, where we've managed to integrate even more closely neurology, neurosurgery, specialist nurse, speech therapist. So that's. So
you basically built that up. I think Marwan joined in 2002, if I remember correctly.
Yes, that's correct. Yes.
And did Ludwig Srinzo came much later, right? Or
yes, I mean he was still quite young then, so he came first as a registrar, and then eventually was able to join us as consultant. But yes, he grew up with the team like many people.
Yeah, great. And if I understand correctly, you co-lead movement disorders with Tom Faultier. Is that correct currently, or?
Well, Tom. Well, I wouldn't say we lead the whole movement disorders. I mean, Tom Faultier and I are the two neurologists in the deep brain stimulation team, so what we call the unit of functional neurosurgery.
Yeah.
But we do have, we do have also other colleagues, specialists in movement disorder, who refer patients but are not directly involved with our program.
Makes sense. Great. So maybe let's talk a bit now about the present and later a bit about the future. So what are you currently involved in? I of course looked a bit at your publications, and there were so many alone in 2020, and you've been so productive throughout your whole career. Is there something that you like currently, that fascinates you most in terms of a research question or clinical question, or is it very diverse these days?
Yes, I mean, it's still quite diverse, I mean, there are still questions to be answered in terms of, as I mentioned earlier, there's still some heterogeneity of outcome. We are both in Parkinson and in dystonia as well. We are currently looking at a large series of dystonia to try also to understand a bit better what are the factors influencing their outcome. We are also preparing a new trial for DBS for Tourette, because we did one a few years ago, but it's not approved in UK. So patients with Tourette cannot routinely have deep brain stimulation, and the NHS has asked for more evidence before deciding on commissioning. So,
which target?
With the pallidum.
Pallidum. Anterior or posterior?
Yes, anterior pallidum.
Anterior. Okay, interesting. Okay, where do you think our field is headed? So, what are the challenges for DBS and maybe neuromodulation as a whole that need to be overcome to move forward and really change things since 30 years? Any ideas?
I mean, as we discussed earlier, I think for closed loop system to really have an important impact, I think we would need a lot of progress with the technology. Ideally we would need multiple small wire in different places that record the signal, and having computer able to interpret all this signal and generate, trying to reproduce more physiological activity in all those circuitry, and then possibly address those that are refractory to the current technique. As you know, the main problem in Parkinson is the problem that are not responsive to levodopa, falls or
symptoms,
cognitive problem. So whether we will be able to do that or not, or whether there will be progress in disease modifying medication, which will means that those techniques become unnecessary. We will see.
How about MR-gated focused ultrasound? Would you, if you were a patient, or if your a close relative would be a patient, what would you prefer, DBS or focused ultrasound?
Well, we do not have access to focused ultrasound in UK, so I have to say I haven't really got any personal experience of it.
But you do lesioning, right?
We do thermocoagulation, yeah. We, in particular in the thalamus. We don't really do in other target. We do in the thalamus. I don't know. I would probably be more inclined towards the stimulation, but I haven't got much experience at all with focused ultrasound.
Maybe one follow-up question about the lesioning versus DBS in tremor. How do you decide usually which one you would do? Is it patient age, or like what are the factors whether to put a lesion or a DBS?
The consideration is only in the thalamus, so it's only patients who are candidate to a thalamic procedure.
You mean VIM, right? And with that also for tremor. Yeah. Okay. Mm-hmm.
Yeah. I mean, sometimes it's. I think for VIM in particular, if it's predominant on one side, we often discuss both options with the patients. So sometimes it's the patient preference. We've had a few patients who escaped the effect of VIM-DBS, for which we then suggested a lesion. I mean, it's still a relatively small number. We've probably done about 20 thalamotomies in the last 20 years.
Yeah. How would you explain that, DBS failed, or not failed, but maybe afterwards the patient escapes the effect due to maybe plasticity, and then pull the lead out, make a lesion, and now it works again? Is there is it even more disrupting information flow there, or even do you have an explanation for that?
Probably in the sense that, I think, there's still a lot of debate around those patients who escape the control of tremor with stimulation, but it's very likely that some pathways develop an abnormal activity, and lesions sometimes no activity is better than bad activity.
Yeah, true. And but that subsequent lesion would not be done via the DBS lead, right? Probably you pull it out.
Yes, the problem, it has been done in some centers. The problem of using the DBS lead is that you cannot control the temperature.
Mm-hmm. Okay. Makes sense. Yeah. So it might be bigger than intended, and of course that we don't want.
Yes, exactly.
Okay. Is there something you think is important for our field, but that is often neglected or forgotten? Maybe something that you thought about back in the time in Grenoble, but now people just ignore?
I don't know. One thing we were looking at the beginning, with thalamic stimulation, we would ask patients to switch off the stimulation at night to try and limit this tolerance phenomenon in the long term. So at the beginning of the STN stimulation, we try to switch it off at night, similarly thinking that it might work less well with time. But clearly that was quite difficult because they had this marked rebound of symptoms when they would stop the stimulation. Yeah. So then we tried to program cyclic modes, but that didn't really work either, because however short was the off, the symptoms gradually came back for that brief period of time. But for quite many years now, STN stimulation has been using continuously. We've never really, although I suppose one could argue that the closed loop might allow to not have a continuous stimulation, which maybe would have some potential advantage.
And the frequency domain. So Pierre Pollak, when I asked him a similar question, he basically said that, especially for new indications such as, depression or OCD, it seems like people just adopt the 130 hertz without even thinking about it. But back then, he went through you all went through all these frequencies and tested. And in the Lancet 1991 paper, we see this beautiful graph of the, tremor effect depending on frequency. Do you think there's a missed opportunity, for example, in OCD to test different frequencies?
Yes, it's possible. It's possible. Nevertheless, it's not as straightforward because, the effect in OCD takes a little bit more time than the effect on tremor or bradykinesia, which means that for the motor symptoms of Parkinson, you can test several frequencies during the same half day. Yeah. But for some conditions such as OCD, it's not so straightforward. I think that will probably happen as there are more patients, and then you can do some longer period of time with different parameters. Great.
And then similar question, but directed at the young and wild listeners of this show. Is there any advice that you would like to pass on to the next generation? Advice to survive in academia, or just thoughts about what we should think about when we pursue research?
Yes, I mean, academia, in particular, clinical academia is certainly challenging, and I think it's also becoming more challenging because there are more and more bureaucracy around research, I would say. There's a lot of things we were doing 20 years ago that now would take us several months of paperwork to be able to do. So, and getting grants and I think papers as well is getting more difficult to have interesting original ideas. So the academic field is certainly challenging, and there are a lot of competing interest as well into it. So what might be more beneficial to the patient is not necessarily what is going to give you a good grant and a paper in Nature. So I think one shouldn't forget why the research is done, and clinical research should aim at improving patient outcome or improving science for the long term. And I think it's a bit sad sometimes to see research just for the sake of writing papers or getting grants, losing a bit what should be the ultimate aim.
Any advice for women in academia?
Well, that's putting an extra obstacle, but I think yes. Well, I think it's certainly important to have women in academia. I think there are more as time goes. I think in this field you need to try and be organized and set times for different priorities, and maybe not expect to be perfect at everything.
Is there something that you think we missed that you would have liked to talk about now, talking about the old times, but the present and the future? Something, that you wished I would have asked?
No, I don't know. You have covered so many activities and made me think of aspects of the past I hadn't thought for a long time.
I can imagine. One gets caught up in the daily routine, I guess, especially in London, maybe, very easily, right? I could imagine. I've once met you very briefly when I visited Vladimir Litvak, and I remembered that you had it seemed like you had a very busy schedule, so with patients, and I can imagine that thinking about Grenoble 1995 is not on your daily routine.
No, but it's an enjoyable memory.
Yeah. Okay. Great. So thank you so much, Patricia. This was amazing. It's always, especially for us young people, I think, but I think for everybody, really enlightening to just hear someone talk who was at the forefront when it all started, at least for movement disorders. And so thank you so much for taking the time. And have a great day.
Thank you. Thank you for asking and for the memory trip.